There's a glass of water on your nightstand right now. Maybe it's half full, the rim catching a little moonlight from a window you never quite close all the way. Maybe it sits on a coaster your spouse bought at a craft fair years ago. Maybe there's no coaster at all, just a faint white ring stained into the wood. A ring that has been forming night after night, month after month, because that glass of water has been there so long, it has become invisible to you. You refill it before bed. You take a sip when you get up. You take another sip when you get up again and again. That glass of water knows something about you that you have been reluctant to admit. It knows how many times you leave the bed. It knows that your nights are fractured, interrupted, broken into segments that no longer resemble rest. It has been a silent witness to a pattern you have written off as aging or a small bladder or too much tea after dinner. And I am telling you today, as someone who spent 17 years in clinical research before walking away from the institutional publishing grind to actually talk to real people, that glass of water is sitting at the scene of something your body has been trying to communicate for months, possibly years. This is not about a glass of water. This is about what is happening inside you every single night, behind the walls, inside the plumbing, deep in the infrastructure of your body, while you shuffle to the bathroom in the dark and tell yourself it is nothing. We now know, with a depth of evidence that would have been unthinkable even 15 years ago, that nocturia, the clinical term for waking 2 or more times per night to urinate, is not a minor inconvenience of getting older. It is a physiological distress signal. And the fascinating, deeply unsettling part is that it rarely points to just one cause. It sits at the intersection of cardiology, endocrinology, nephrology, and neurology, like a crossroads where 4 different highways converge, and the traffic jam that results is what wakes you at 2 a.m. Let me unpack that junction for you, carefully. Because you deserve more than a list of scary diseases. You deserve to understand the engineering. Your body runs on a fluid regulation system more intricate than the plumbing in a 70-story skyscraper. During the day, your kidneys, specifically the nephrons, roughly 1 million microscopic filtration units per kidney, process about 180 liters of fluid. They reabsorb most of it. They calibrate. They respond to hormones, blood pressure, sodium levels, glucose concentrations. They are performing a calculation every second of your life that most people never think about. At night, a hormone called antidiuretic hormone, ADH, also known as vasopressin, rises in your bloodstream. Its job is elegant and specific. It tells your kidneys to concentrate urine, to pull water back into circulation, to let you sleep 6, 7, 8 hours without needing to void. Think of it as the night shift manager at a water treatment plant, dimming the output valves so the system can rest and repair. Now, what happens when that manager stops showing up? You produce more urine at night than your bladder can hold. You wake, you walk, you urinate, you go back to bed, and 45 minutes later, you do it again. Your sleep architecture, the cyclical progression through light sleep, deep sleep, and REM, shatters. And sleep, as we now understand it, is not a luxury. It is the period during which your brain clears beta amyloid proteins through the glymphatic system. Your cardiovascular tissue undergoes repair. Your immune cells recalibrate, and your metabolic hormones reset. Every interruption costs you. Not in some vague, hand-wavy way, in concrete, measurable, biological currency. We are going to walk through 5 specific systems in your body that may be driving this nighttime pattern, and I want you to pay close attention to which one resonates with your experience, because the cause determines the solution, and the wrong solution, applied to the wrong cause, does nothing at best and causes harm at worst. The first system is your heart. This may surprise you. Most people do not connect urination with cardiac function, but the link is well established in the literature, and frankly, it is one of the most under-discussed relationships in outpatient medicine. When your heart is not pumping with full efficiency, a condition broadly called heart failure, Though failure is a misleading word, because the heart hasn't failed so much as weakened, fluid accumulates in your lower extremities during the day. Your ankles swell. Your shoes feel tight by evening. You may notice sock lines pressed deep into your skin. Then you lie down. Gravity stops holding that fluid in your legs. It redistributes centrally. Your blood volume effectively increases. Your kidneys, sensing this sudden surplus, do exactly what they are designed to do. They filter it out. And you wake up needing to urinate. Not because you drank too much, but because your heart couldn't manage the fluid distribution while you were upright. Look at your ankles tonight before you get into bed. Press a thumb into the skin just above the bone on the inside of your ankle. If the indentation lingers, if it takes more than a couple of seconds to bounce back, that is called pitting edema, and it is telling you something about your cardiovascular plumbing that you should not ignore. The second system is your metabolic engine, and this is where the story gets layered. Type 2 diabetes, or even its precursor state, insulin resistance, can drive nighttime urination through a mechanism that is almost cruelly straightforward. When blood glucose levels remain elevated, your kidneys cannot reabsorb all the glucose passing through them. The excess glucose pulls water with it osmotically through the proximal convoluted tubule and into the collecting ducts, and out it comes as urine. More glucose, more water, more trips to the bathroom. But, and this is the part I wish more primary care physicians would explain, you do not need a diabetes diagnosis to experience this. A fasting glucose of 110, which many labs still mark as borderline or pre-diabetic, can be enough to trigger increased nocturnal urine production, particularly if your evening meal was carbohydrate heavy. A big plate of pasta at 7 p.m., a slice of pie after dinner, a glass of orange juice before bed. The body does not lie about its glucose management. It has no reason to. Your third system, and I want to take a slightly slower approach here because this one tends to catch people off guard, is your prostate gland, if you are male, or your pelvic floor, if you are female. In men over 50, the prostate gland, which encircles the urethra like a ring around a pipe, gradually enlarges. This condition, benign prostatic hyperplasia, or BPH, is so common that some urologists consider it nearly universal in men over 70. The enlarged gland compresses the urethra, creating resistance to urine flow. The detrusor muscle, the muscular wall of the bladder, has to work harder to push urine through the narrowed passage. Over time, the detrusor thickens. It becomes overactive. It starts contracting when the bladder is only partially full, sending you urgent signals at volumes that would never have triggered a trip to the bathroom 20 years ago. For women, the pelvic floor tells a parallel story with different characters. After menopause, declining estrogen levels weaken the musculature supporting the bladder and urethra. The bladder may descend slightly, a condition called cystocele, and its capacity effectively decreases. The trigone, the triangular region at the bladder's base where the ureters enter, becomes more sensitive. Urgency increases. Frequency follows. And in both cases, the nighttime pattern is the most disruptive because the biological braking system, the ADH we discussed, may also be declining with age, compounding the problem. Anyway, the fourth system is one that the research community has only recently begun to appreciate fully, and it connects two fields you might not expect: sleep medicine and nephrology. If you snore heavily, or if your partner has ever told you that you stop breathing in your sleep, you may have obstructive sleep apnea. And obstructive sleep apnea drives nocturia through a mechanism that is, I have to say, almost perversely elegant in its physiology. When your airway collapses during sleep, your diaphragm continues to contract against a closed passage. This generates significant negative intrathoracic pressure. Your heart's right atrium stretches. The stretched atrial wall releases a peptide called atrial natriuretic peptide, ANP. ANP tells your kidneys to excrete sodium and water. You produce urine. You wake up. So you are not waking up because you need to urinate, exactly. You are urinating because your airway collapsed, which stressed your heart, which triggered a hormonal cascade, which activated your kidneys. The urination is the last domino in a chain that began in your throat. We now know that treating sleep apnea with CPAP therapy or oral appliance therapy or positional changes can reduce nighttime urination by as much as half in some individuals. That is not a small effect. That is a transformation. And the fifth system, I almost hesitate to name it because it tends to frighten people, and I do not want to provoke anxiety where none is warranted, is your kidneys themselves. Chronic kidney disease affects an estimated 37 million adults in the United States, and the majority of them do not know it. The kidneys lose their concentrating ability gradually, the way the foundation of an old house settles so slowly that you don't notice the cracks forming in the walls until one day a door won't close properly. Your kidneys can no longer produce concentrated urine at night. They need more water to excrete the same amount of waste. Volume increases. You wake. If you have high blood pressure, particularly if it is poorly controlled, or if you take NSAIDs regularly for joint pain, or if you have a family history of kidney disease, this possibility deserves a conversation with your physician that goes beyond a basic metabolic panel. Ask for a cystatin C measurement. Ask for an albumin to creatinine ratio from a urine sample. These tests are inexpensive and available at any standard lab, and they provide a far more complete picture of your kidney function than serum creatinine alone, which can appear normal even when you have already lost 30 to 40% of your filtration capacity. Now, and I want to be clear about this because complexity matters and oversimplification helps no one. These 5 systems do not operate in isolation. This isn't black and white. A 68-year-old man with mild heart failure, borderline glucose, an enlarged prostate, and moderate sleep apnea is not dealing with one cause. He is dealing with 4 causes stacked on top of each other, each one making the others worse. The fluid retention from heart failure increases kidney workload. The sleep apnea worsens blood pressure. The elevated blood pressure accelerates kidney damage. The disrupted sleep from Nocturia impairs glucose regulation. It is a cycle. Actually, let me say that differently. It is a debt spiral, where every unpaid balance accrues interest on the others. And the cost of ignoring this spiral is not theoretical. A 2019 study published in the Journal of Urology followed over 4,000 men over the age of 50 and found that those who urinated 3 or more times per night had a significantly higher rate of cardiovascular events over a 5-year period compared to those who slept through the night. The Nocturia did not cause the heart attacks, but it was a window into a cardiovascular system already under strain, a warning light on the dashboard that was flashing long before the engine seized. A separate analysis from Tohoku University in Japan, published in 2020, found that Nocturia in older adults was associated with a 27% increase in the risk of falls. Navigating a dark hallway at 3 a.m. with impaired sleep reflexes and quite often orthostatic hypotension, a sudden drop in blood pressure upon standing, is exactly the kind of compounding risk that breaks a hip, ends independence, and rearranges the entire remaining trajectory of a life. So what do you do with all of this? First, you stop treating it as inevitable. The normalization of frequent nighttime urination among older adults has done enormous harm, and I say that with full awareness of how that sounds. It is one of those comfortable falsehoods, oh, that's just what happens when you get older, that delays diagnosis and allows correctable conditions to progress into irreversible ones. Yes, some increase in nighttime urination frequency is a normal feature of aging. Going from 0 trips to 1 is, for most people over 65, unremarkable. Going from 1 to 3 or 4 is a different conversation entirely. Second, you take a systematic approach. Keep a voiding diary for 72 hours. It sounds tedious, and it is, but it gives your physician more useful information than almost any single test. Write down what you drink, when you drink it, when you urinate, and roughly how much. The pattern that emerges will often point directly to the primary driver. If you are producing most of your urine at night, a condition called nocturnal polyuria, the cause is likely hormonal or cardiac. If you are producing small volumes frequently, the cause is more likely bladder-based or prostate-related. Third, look at what you consume after 6 p.m. Caffeine has a half-life of 5 to 6 hours. A cup of coffee at 4 in the afternoon is still exerting 50% of its diuretic effect at 10 p.m. Alcohol suppresses ADH directly. That is its mechanism, not just a side effect. And even a single glass of wine with dinner can increase overnight urine production measurably. Reducing evening fluid intake by even 30% in studies out of the University of Bristol reduced nocturia episodes in subjects with no underlying pathology. Fourth, and this is the part where people tend to feel uncomfortable because it requires a doctor's visit. Get the basic blood work done. Fasting glucose, hemoglobin A1C, a complete metabolic panel including creatinine and BUN, a B-type natriuretic peptide level if your ankles swell, a PSA if you are male and over 50 and have not been screened recently. These are not exotic tests. They are available at every primary care office in the country, and the information they return can reshape your understanding of what is happening inside you in ways that no amount of guessing or Googling can replicate. Fifth, talk to your physician about a sleep study if you snore, if you wake with headaches, if your partner has noticed apneic episodes, or if you feel unrested despite what should be adequate hours in bed. The connection between sleep apnea and nocturia is strong enough that some sleep medicine specialists now consider frequent nighttime urination a screening criterion for referral. I want to leave you with something that I have been turning over in my own mind for several years now. Ever since I stepped away from full-time research and started, it was February, the kind of gray February where everything feels suspended. Started actually listening to patients rather than just reading about them in cohort studies. The body does not have a public address system. It cannot tap you on the shoulder and say, your heart is struggling, or your kidneys are losing ground. What it can do is change your behavior. It can make you get up. It can make you walk to the bathroom. It can interrupt the one process, sleep, that you value enough to notice when it is disrupted. And if you think about it that way, nocturia is not the disease. It is the body's last resort for getting your attention. The question is whether you will pay attention or whether you will keep refilling the glass on the nightstand and telling yourself, this is just how it is now. That glass of water will be there tonight. It will catch a little light. You will reach for it. What you do after that, whether you let this be the night that shifts something, that prompts a phone call, that opens a conversation you've been putting off, I cannot decide for you. But I wonder what your answer will be. I'm Dr. Albert Winslow. If this reached you at the right time, share it with someone you care about who is still walking to the bathroom in the dark and calling it normal. Subscribe if you want more of this because we are just getting started. And that glass of water, leave it there. But know what it means now.